Hi, I'm Dr. Matt Brinkman, and I'm going to talk to you a little bit about gastroparesis today. I do gastroparesis therapies in my practice. About 50% of my practice is gastroparesis, and it's an unusual therapy. I think I do some talks nationally for this, and I did one in the summer of 2015, which we broadcast on Periscope, which some followers on Twitter saw. And there were some people who missed it. And, if you know Periscope, it kind of goes away after 72 hours. So we thought we'd put something together, put it on the website, and hopefully this is informative to you. First thing we probably should do is just define what gastroparesis is. Gastroparesis is a slowing of the emptying of the stomach that's not related to a blockage. Clearly, if there's a mechanical blockage of the first part of the intestine or the end of the stomach by a tumor or scarring, that's going to lead to gastric slowing. But that's not what we're talking about. What we're talking about is somebody who appears to have a normal stomach, but it's not emptying properly for a functional reason. So delayed gastric emptying can lead to all kinds of symptoms. And generally speaking, people experience bloating and fullness, nausea with or without vomiting, acid reflux, and abdominal pain. Now, you think about those symptoms, they're pretty generic. There's lots of different things that can give you those symptoms. You can get those symptoms from gallbladder disease, gastritis, hiatal hernia, H. pylori, gastric ulcers, duodenal ulcers. So the problem with the upper abdomen is almost everything gives you those types of symptoms. And so generally speaking, people are going to go through a long process of self-treatment and then some diagnostic workup by their doctors before they get diagnosed with gastroparesis. The underlying cause of the slowing is what we're a little more interested in. Slowing is basically a symptom of other disease processes. We think of gastroparesis as being diabetic and non-diabetic. Non-diabetic has another term called idiopathic, which means we don't know what causes it. When we look at diabetics, about 5% of the type 1 diabetics will develop gastroparesis that's symptomatic over their lifetime. About 1% of type 2 diabetics will get it. Now, diabetic gastroparesis is a type of neuropathy. And so for the diabetics out there, neuropathy can mean painful feet, tingling in the feet or the hands, and other types of like retinopathy. So it takes a while to get it. So most people are going to have diabetes for about 10 years or more before they develop significant gastroparesis. We don't think of it commonly in people who are just diagnosed with diabetes unless they've been untreated for a long period of time and they just come to therapy. So that's not most people in this country. For the idiopathic gastroparesis, it's a much smaller number. It's about 0.2% of the total population. But there's just way more people that are non-diabetic in this country. So in all, there's actually more people with idiopathic gastroparesis out there than there are diabetics. Unfortunately, most physicians don't think of it as being a very common disease, and they'll think of diabetic gastroparesis when a diabetic comes in with nausea or vomiting. But because of all the crossover with other diseases that are much more common, again, gallbladder disease, ulcers, gastritis, etc., they won't think of gastroparesis as the first item of interest when a patient presents with those symptoms. Diabetics and non-diabetic or idiopathic gastroparesis, they present differently. They're kind of different disease processes. And so the diabetics tend to have more nausea and vomiting, bloating symptoms, but less pain. The idiopathics tend to have nausea with less vomiting, but a much higher incidence of epigastric abdominal pain as a component. And so that's pretty clearly seen when we look at these populations. And so that can help direct somebody when they see a patient with these symptoms. A common statement I hear from the patients I see is, I've had pain for so long, my doctors aren't trusting me and my symptoms, and they say that pain doesn't come with gastroparesis, and that's clearly not the case. If we look at the literature around gastroparesis, especially idiopathic gastroparesis, 80 to 90% of patients who come to medical care for gastroparesis will complain of abdominal pain as one of their symptoms. Now, A much smaller percentage, only about 20%, are going to have that as their primary complaint. But if you do a good history, they'll describe nausea, vomiting, bloating. Oh yeah, I also get pain after I eat. It's just not the primary presenting symptom. So the purposes of this conversation we're having, we're going to divide gastroparesis up into kind of three big buckets. The diabetic gastroparesis, and then the idiopathic gastroparesis we're gonna put into two subgroups. There's post-viral and then the post-surgical. They're treated slightly differently, and so it's important to try to figure out who has what. As I mentioned when we were talking about incidence, the biggest number of patients is going to be the idiopathic gastroparesis. These are typically middle-aged women or younger women, 35 to 45 at presentation. Many of them are going to have an antecedent or preceding viral illness, whether it's respiratory or gastrointestinal, the flu, for lack of a better term. And then after that, develop significant nausea, vomiting that sometimes leads to hospitalization, and it just persists. It keeps on going on. And then the physicians are sort of at their wits' end to try to figure out what's going on. That's the most common presentation. When we look at post-viral gastroparesis, there's been lots of studies. The one thing we know is it can get better over a year, and some people are going to experience spontaneous remissions. And so typically, as somebody who does gastroparesis therapy as part of my work, I'll wait on those people until they've had to just make sure it's not going to get better on its own. Now, most people who come to me have had symptoms for multiple years, and so we know that they're not going to resolve spontaneously, but some don't, and for those we wait, and we do other therapies that you'll hear about a little bit later in this talk. There's been some studies on looking at the viruses that can cause this. Cytomegalovirus or CMV, Epstein-Barr virus, herpes or herpes zoster. Those can all be associated with the development of gastroparesis. And so if you have had those diagnoses and now you're having significant abdominal pain or nausea or vomiting, there's a possible link there. Less common in numbers but dramatic in presentation are the folks who have post-surgical gastroparesis. And that's a physical disruption of the nerves that go to the stomach at surgery. And this used to be really common with ulcer surgery. Back 25 years ago, we did a lot of surgery for ulcers. And one of the major procedures that was done involved dividing the nerves that go to the stomach. Now, we don't do ulcer surgery that frequently any longer because we have great medications that allow us to not have to do it. But we do other surgeries where we work around the food tube or the esophagus, and we're working on these nerves. And those are mostly done for gastroesophageal reflux disease or heartburn, and then hiatal hernias. And, if you just look at the surgical series, there's at least a 1% incidence of damage to these nerves during these procedures. They can be hard to identify. Sometimes the anatomy is very abnormal when these procedures are being done. And if they're damaged, they can lead to significant gastroparesis symptoms. A final cause of gastric slowing that's not really gastroparesis is drug-induced gastric slowing. This is clearly most common with the narcotic pain medicines like Percocet and Dilaudid and morphine and the others. Narcotics have a direct effect on the bowel and have direct slowing of the bowel. So somebody who's on chronic narcotic therapy, most commonly for back pain, those people can often see chronic constipation and chronic gastric slowing. And the mainstay of therapy there is to see if there's another medication that could work versus the narcotic. Because if you can get them off the narcotic, many times it'll just get totally better. There are other medicines that can do it too. Anticholinergic medicines, those are mostly antiemetics like Phenergan and Compazine, scopolamine patch. Cyclosporin and antitransplant medicine will do this the same. And interestingly, a medicine called Byetta and the other GLP-1 analogs, these medicines are used for diabetes. They are a synthetic form of a naturally occurring hormone that the intestine makes that helps your body digest and absorb glucose and sugars from your body. And we know that through some studies that were done a long time ago that direct infusions of that hormone cause gastric slowing. And so the main side effect of Byetta is gastric slowing and nausea. And so we use it in diabetics. And so some diabetics have gastroparesis. Now we can exacerbate it by using one of the medicines. So if somebody who's a diabetic gets put on Byetta and they start vomiting like crazy, or they have a lot of food intolerance, they're going to need to come off that medicine and try a different medicine. And the symptoms will resolve with cessation of the medication.